So again, I want to say hello to everyone. For the people that are joining just now, just connected with us. We should start in 2 minutes from now. And for the time being, do introduce yourself. You see that you have on the left side of your box, of your screen, a chat box that you can, it's where you're gonna put your questions, you can make your comments during the whole presentation. Hello, Olavo, nice to have you here. Hello, Ebu from Turkey, Istanbul. Maya from Taiwan. I think I have seen you already in our previous webinars. Nikki, the audio is on. I hope you can hear us. Mohammed, it's really nice to have you here from Gaza Strip. Charles David, welcome for this webinar, Charles, connecting from Croatia. Hello, Hamza, nice to have you here. All right, everyone. So let's start the webinar. I want to welcome each of you again. For the ones also that just joined the webinar room. My name is Márcio Galeato. I am a psychologist and also a member of the Mental Health and Psychosocial Support Network. I'm connecting from São Paulo, Brazil. It's very early morning here in this time zone. And we are super excited to welcome you for this webinar, this very important webinar on mental health and psychosocial support and DRR, disaster risk reduction, which has been a field that is slowly getting the attention to see the synergies and the necessity to start another level of interaction and discussion. So basically, just to explain a few, before I introduce the presenters today, I just want to explain to you a bit of how this webinar is going to work. You have on the left side of your screen this chat box where you can, it's where you're going to use to interact to each other, to make comments about the presentations, and more importantly, it's where you're going to also make the question that we are going to collect your question, and we're going to save your question to the end of the webinar. So after the Fahmy and Lennart, they make their presentations at the end, we're going to have about 15 to 20 minutes of questions and answers session. Okay? So do use and make your question at any moment during the presentation. And my colleagues and I, we're gonna have them later for Fahmy and Lennart. At the end of the webinar, we are going to also post a link here for the exit survey. Do make your comments. It's very important for us for evaluation of the webinar itself. And also I want to remind you that this webinar is being recorded, and later on you can also watch it again, or you can send it to someone, the link to this webinar that will be posted at our website, Mental Health and Psychosocial Support Network. So we are going to start with Dr. Lennart Reifels, and let me mute him. Lennart, can you hear me?
Can you hear me, Matthew?
Yes, now I can hear you. Can you share your screen, your webcam? Yeah, you're coming. Nice to see you, Lennart. So as a brief introduction, which we want to welcome you and thank you very much, Lennart, for your availability for this webinar. He's connected from Melbourne, so the other side of the road. Dr. Lennart Reifels is a research fellow at the Center for Mental Health, Melbourne School of Population and Global Health, University of Melbourne, and visiting research fellow at the Disaster Research Unit, Department of Political and Social Science, Free University of Berlin. Dr. Lennart has extensive research and work experience in academic and national mental health servicing settings in Australia and Germany that encompass research, direct service, and national training and in management roles. His key research areas includes population mental health systems and service research, disaster risk reduction, and strategic adaptation in view of the globally increasing impacts of the extreme climate events and disasters. So it's a very extensive profile, Dr. Lennart, and I leave the room to you for your presentation.
Hello, everybody. It's a privilege to have this fantastic global network of practitioners and people interested in this particular topic, which has been an interest of mine also over the last couple of years, and a privilege also to be sharing this space with Fahmy, obviously, who is well known to many of you already. Yeah, like Matthew said, it's been a long day here in Melbourne. It's about 9 o'clock, and it's been a long hot day as well. And I should issue a small warning. My partner is traveling at the moment, so if there's any kids ghost walking in the background, I hope you don't mind, and forgive me for that. That may or may not happen. But look, it's fantastic to see that there's such great interest in this particular topic. And as many of you will know, disaster risk reduction and MHPSS, or sometimes also disaster mental health, have been sort of fairly separate communities of practice for a little while. So it's for some time I was under the sort of illusion that I might be the only person interested in it. So it's great to be proven wrong in that respect, for sure. So today, essentially, I think I have about 20 to 25 minutes to take you through some of my thoughts around this, and I'm really keen to hear your feedback and how you're connecting those two things in practice. And as Marcia said, I'm coming more from probably an academic angle, but yeah, whenever something becomes too nerdy and too conceptual, I'll issue a little slide warning as well. So hopefully we can go through that quite quickly. But today for me provides an opportunity to look at MHPSS through a disaster risk reduction lens. So what happens if we look at this field of practice, if you like, through the lens of the risk concepts that disaster risk reduction entails? And let me see if I can maneuver these slides here for you and move on to the next one. So essentially what I'm hoping today is to look at the merit and also the challenge of the, if you like, DRR paradigm for MHPSS. Look at some of the interlinkages, conceptual, policy-wise, but maybe also in terms of the actual practice. And there's different ways to approach these, I guess, and the place that I might start from is to look at the Sendai Framework, a global DRR policy framework that's quite seminal at the moment, started in 2015, and will guide global DRR efforts at global, regional, national, and local levels over the next 15 years. and look also then at a brief overview of that, at the place of mental health within it. And then I might draw upon a study which I conducted and had the good fortune to spend some quality time in Europe to speak to many of your colleagues there who are experts in this particular area, and to sort of see what happens if we apply that risk lens, disaster risk reduction lens, to this very MHPSS practice field. So I was very much interested in seeing what are the principal mental health risks in emergencies, and what are some of the key strategies maybe to address these risks. And maybe it's not always that we think about mental health necessarily in risk terms. And another area of interest of mine was sort of what does it take to get these two fields to collaborate better together, and what are current challenges in that space and opportunities as well. So that's in a nutshell what I'm trying to sort of get through and get to today. Now, many of you will have at least heard of the Sendai Framework for disaster risk reduction, and also that it's the first of the post-2015 Agenda Global Treaties, a UN treaty, which was signed by 187 UN member states in March 2015. So it almost doesn't matter where you're working and where you're working from. The country in which you're in would be a signatory to this particular agreement, which also means, I mean, similar to climate change agreements, it's not necessarily binding, but there are commitments that have to be fulfilled, and countries have to report against the targets that have been set as well over time. It's quite important to note that the Sendai framework, compared to other predecessor frameworks, embodies quite an important shift. And it's both in terms of not just focusing on natural disasters or natural hazards anymore, but also man-made hazards, even biological hazards, environmental hazards, and the like, that may well lead to catastrophes and disasters. So a broader disaster focus and scope, but also, and this is important, the shift away from managing or merely managing the impacts of disasters, and quite often we come too late when things have already occurred, towards more reducing disaster risks. So the question is, what can we do in the lead up to actually prevent those things from occurring in the first place, or to ameliorate these sort of adverse consequences that disasters and natural hazards and other hazards typically entail. And I won't sort of labor this too much, but the framework is structured around a global goal and outcome and 7 global targets. So there's accountability built into this framework that can be sort of defined at various levels, regional, local, but also national. And it's very important within it that we actually get a better understanding of what disaster risk actually entails. So that's one of the 4 key action areas, the others being strengthening disaster risk governance, investing in disaster risk reduction, and enhancing preparedness for effective response and to build back better, which is also coincidentally where mental health appears to be placed. And yes, health resilience is promoted strongly throughout. So the overall expected Sendai outcome is quite broad and quite daunting in terms of what it tries to achieve. It is the substantial reduction of disaster risk and losses in lives, livelihoods, and health, and in the economic, physical, social, cultural, and environmental assets of persons, businesses, communities, and countries. So it's really quite ambitious. But what sets this framework apart from many others is that it actually focuses a fair bit on implementation and provides clear guidance around how this could be done in practice. Not so much necessarily for the mental health part of it, but that's why we're here today, to explore that a bit further. Yeah, just a nice little colorful illustration of these 7 global targets. So essentially, we're looking at a reduction in the mortality, but also in terms of the people affected by disasters and hazards, measurable reductions in that. And that also relates to sort of people who might become ill or illnesses that could be measurable as well. Economic losses, and also obviously damage to critical infrastructure and disruption of basic services, including health and also education services. And the 3 global targets you find on the right-hand side are both targets in and of themselves, but also means to an end, in that they entail sort of national DRR strategies that have to be put in place. So each country defines within its own jurisdiction what needs to happen here to sort of work towards that global goal and to be accountable towards it as well at a national level. International cooperation with developing countries needs to be improved as well. And also the multi-hazard early warning systems and disaster risk assessments at a national level and at various levels are quite pivotal to all of this as well. So that perhaps as an overview of the framework as such. Now let's take a quick look at the place of health and also of mental health within Sendai. And it's notable that there actually, if you look through it, and people have come up with different counts, interestingly, there are 39 references to health explicitly within Sendai, which is a big shift from the predecessor Hyogo framework. 4 out of the 7 global targets make direct links to health. And there's a strong emphasis on the resilience, on promoting the resilience of health systems, on reducing mortality, as I said, population well-being, and also early warning at the center. When it comes to mental health, and this is really the first time that mental health has been explicitly mentioned in the DRR framework, it sits under priority 4, as I said before, both at the national and local level. And the key phrase here is enhance recovery schemes to provide psychosocial support and mental health services for all people in need. Now, some of my colleagues have sort of jumped to the conclusion to say this is sort of actually equates almost the fact that mental health might have been mainstreamed in this framework, which in my personal view might be taken it a bit too far. It's a very hopeful view, and there's a lot more work to be done. So we need to sort of define what actually needs to happen here and how those two areas connect. But I might also briefly flag other connection points, disaster medicine, training capacities in that field. And for those of you who may be working sort of more from a disability perspective, perhaps psychosocial, psychiatric disability perspectives, that is also being anchored within the framework. So health resilience is promoted strongly throughout at various levels, and mental health also for the first time features through this statement. You can see there in the middle in ADR framework. Now, I might lead into a study which I've had the good fortune to conduct a year or so ago. Essentially, if we come from a DRR angle, it's clear that effective DRR hinges on concerted integration within specific health domains and also established fields of practice, such as our own field or the field that you may be working in, MHPSS. But obviously, Sendai being a global agreement, a UN agreement as it is, sort of is limited to the extent that it can provide guidance for specific fields of practice and can prescribe or inform, provide guidance around what needs to happen in particular areas. And it is therefore important that DRR turns to MHPSS experts and also practitioners to better understand and reduce the risks that present in relation to mental health in emergency and disaster contexts. So the study aim essentially was to examine the principal mental health risks in disaster context and also to explore the broader implications of that broader DR policy shift towards reducing disaster risk, not just responding to the impacts for MHPSS. In terms of the method, I interviewed a number of your colleagues, 31 all up, and 17 of those were European, or at least European-based disaster mental health. Sometimes I use those, I have a fairly broad definition, I should confess, of disaster mental health. I use them synonymously. I find them inclusive of psychosocial aspects as well. In Europe, 3 of them or 4 of them were based in the UK, 7 in the Netherlands, and 3 in Germany, and 3 were affiliated with European-based institutions. A lot of them not just working in their own country, but also more broadly across the boundaries of Europe. And as I was saying, I was quite interested in sort of their understanding of what are the key disaster mental health risks or the mental health risks in disaster and emergency context that you are seeing. What are also some of the strategies to address those risks? So what do you typically do to reduce those risks? And then to look at integration and opportunities and also challenges between the two fields, DRR and MHPSS more broadly. So the key question, what would you regard as the principal mental health risks in disaster contexts? And each of you may want to ponder that just for a second and might come up with quite interesting and perhaps diverging or congruent answers as well. So when we did ask the experts, and there's a number of themes that came out of this, it was interesting that sort of one of them seemed to revolve around what are common risk factors, and I'll go into this in just a second. There's a bit of a vocabulary already in the mental health field, sort of an understanding that certain risk factors lead to certain mental health outcomes, and there's a range of those. Another principal mental health risk in disaster context related was more contextually bound to the unfolding refugee and migrant crisis in Europe, which a lot of the practitioners and experts were directly involved in, either inside of Europe or also outside of it. And then the 3 other ones, which, can I use the mouse here actually? Is that visible to you? I might just try. So these other three here were related more to sort of the risks that are associated with actually providing quality or the appropriate response, the coordination of the response, communication around disaster responses and emergency responses as well, which might well have their own risks associated with them. Okay, mouse is not visible. Thank you. All right. I won't bother with the mouse then. Great. This might be quite small on some people's screen. I apologize, but I won't label this too much either. But common risk factors, essentially, like I was saying, the field does seem to have a language around risk factors for adverse mental health outcomes, and those are well established, and there's systematic reviews out there relate to the nature of the hazard and the sort of the extent of the exposure, loss, obviously, of persons, resources, and livelihood, the lack of social support in its various manifestations, distress, and also there's an understanding that certain groups are particularly vulnerable, including those with pre-existing difficulties or severe mental illness. Those are particularly isolated, children, the elderly, and so on and so forth. And obviously in those contexts, secondary stresses play quite an important role as well. So they are clearly acknowledged as a risk factor in a mental health sense as well. Now, the emerging risks in the context excuse me, of the refugee crisis in Europe were more related perhaps to the sort of underpinning physical and social determinants of health. So displacement obviously was considered by many experts here as a major risk factor in terms of mental health. The loss of continuity of care, family separation, missing person situations which remain unresolved, provide no opportunity for closure or appropriate mourning. For the younger generations too, disrupted education and life development paths more generally can also be a clear risk factor, as well as more at a more basic level, malnutrition, which affects obviously sort of infants and normal infant development, and also the mother-child bond and things like that. So those were the two common risk factor and emerging risks that we identified. The other three themes that came out of the principal mental health risks discussion were more related, as I was saying, to the provision of appropriate mental health support. So there's a little bit of wisdom in these slides, even though the writing might be quite small, so I can apologize. So the recognition, or often the lack of the recognition of the complexity of mental health impacts and how varyingly those might manifest themselves may lead well to sort of not appropriate responses. So, for example, failure to detect those with persistent mental health problems, whether the broader majority that may well experience initial transitory distress reactions, is quite an important distinction and can lead sort of to wrong estimations of service needs and also misguided responses. A sole focus on PTSD, which sort of in the clinical field in particular has been a bit of a preoccupation over the last couple of decades, has been seen as a risk perhaps in and of itself as well. So a broader focus might be needed on broader psychosocial outcomes and factors in this context as well. And obviously the mismanagement of normal human reactions to, if you like, abnormal events is something that is, amongst laypersons at least, sort of often quite common. In terms of the provision of appropriate mental health support, I think people feared that the use of ineffective interventions may happen, and quite often we're still lacking the evidence for a lot of these sort of lower level interventions in particular. There's something coming through now in terms of the research, but it's still sort of very much an evolving field. There's sort of a bit of a balance also between a proactive intervention stance and one of more watchful waiting, if you like. So when do you intervene? When are you going to be proactive? And when is it okay to let people be and find their own resources? Is sort of a bit of a tightrope walk for responders sometimes as well. As far as response communication and coordination goes, top-down approaches were seen to have adverse impact sometimes as well, and also very much the responder behavior on the part of politicians sometimes as well was seen to be linked to public sentiment and could have an impact on that as well. The lack of communication or communication issues, the uncertainty that comes with it, unintended consequence of communication, and also challenges in communicating risk in disaster poor countries. So in Europe in particular, which may not see disasters quite as frequently as Asia sometimes does, there are challenges around sort of even communicating existing risk that is real, but perhaps harder to communicate sometimes as well. Now I might move on in the interest of time to, and this is a nerd alert here on this little slide. So for those of you who want to zone out and have a micro sleep for a second, please feel free to do that, and I'll meet you on the next slide. This is my attempt at systematizing a little bit some of those risks that have emerged here. And essentially, it's sort of an MHPSS risk typology, if you will. And the principal risks that from that information we gain from the practitioners and experts in the field could be sort of differentiated into 3 different principal risks. And type A could be the one that is relating to newly emerging or exacerbated mental health issues among disaster-affected populations. Different from that would be type B, which would be adverse impacts on existing mental health support systems. And again, different from that are the ramifications of both of those, if you like, secondary effects of type A and B on individual, community, business, and also societal functioning. If you take that further, you could also identify some more intermediate risks, which relate to the lack of MHPSS preparedness or capacity, which is obviously something that I'm sure many of you would be familiar with as you sort of move into a new conflict or emergency zone. The challenge also of poor quality, lacking efficiency, efficacy, and coordination of MHPSS responses might well constitute another key risk. But you could argue that those type D and E type risks are probably definitely ongoing challenges of the field, but they could probably be more subordinate to really addressing the ABC type risks, which are the principal risks for why we are in this field and that we're seeking to solve and to reduce. All right, I'll meet you back on the next slide. Not just interested in obviously in the risks and how people understand those and how we can better understand them in this field more broadly, but also getting a better understanding of how these risks are being addressed currently. So through which key strategies is the field currently addressing these risks was one of the key questions that I asked people. And obviously the development of psychosocial guidelines and response plans was a pivotal element to this, which informs a lot of the activities in this place. And obviously the IS guidelines are quite influential and important, and I think Fahmy might sort of make reference to that in his presentation as well. But also there were some interesting mechanisms mentioned to identify and direct people to appropriate support. So this is about providing access to support, which we know in disaster and emergency contexts often there's several challenges around that. So information and advice centers were obviously sort of one very commonly used method. Norway and the UK also used screen and treat approaches. Disaster health registers are also another interesting one, which there's some interesting papers around that now have been successfully set up in the UK. It takes a little while to set up, but it's quite useful in terms of getting people in touch with the resources that they need following a disaster. Health passports, which I'm sure many of you would probably be more familiar with than me, for refugees were also sort of mentioned as something that could provide more continuity as people migrate across borders, potentially in terms of access to vital medications and the like, by using generic names rather than sort of brand names in particular. Yes, there are a range of psychosocial and mental health support strategies, which I probably don't have to tell you about, sort of from generic psychosocial support, early intervention, to the creation of safe spaces for particular at-risk groups such as children, and also women in particular in these conflict zones are very common. But also more sort of general approaches to providing advocacy to build back better. And the WHO has got some fantastic frameworks and case studies around this as well, which are quite informative. Strengthening mental health systems as such is obviously something that also has merit in a disaster context. And I think another well-trodden and important path is also the integration of mental health in primary care more broadly, were being mentioned as strategies to address some of the risks that people have identified as priorities. Now, in the lead up to emergencies, there's obviously disaster preparedness planning required. First responder training, organizational supports need to be set up for staff and otherwise policy-wise. Multi-agency planning is something that was seen to be quite valuable. Mapping existing services too in a particular area is something that is critical to putting people in place with the service they need and identifying gaps that need to be filled as well. vulnerability and needs assessments, obviously something that you may be involved with, and also the inclusion of vulnerable groups in preparedness planning was seen to be quite critical to actually having the impact that you desire and to meet the needs that are actually existing on the ground. On balance, and it's probably fair to say though, and I've got the acronym DMH, disaster mental health, in here, but I have a feeling the same might hold true for MHPSS, and again, I use these synonymously because there's a large overlap. It's probably fair to say that MHPSS is focusing mostly on the response and recovery phase. So it's obviously also easier to get resources around that. It's difficult to get funding for things that haven't happened yet, obviously. But a lot of the emphasis has been sort of on the response, emergency response and recovery phases, if you like, in particular. So, which led me to sort of cheekily sort of ask if MHPSS does need disaster in a way, which is a tiny bit cheeky, but it's meant to provoke thinking around the need for thinking about what we can do actually in the lead up. It reflects that paradigm shift from merely responding to things that have happened, or as a colleague of mine called it, to mop up after the event, to put out fires when they have happened, to see what in this particular field that sometimes also calls itself post-disaster mental health, we can actually do more proactively to build resilience and to prevent disasters from occurring in the first place or their adverse consequences on mental health as well. And there might be a range of strategies in relation to that. I'll be quite interested in your thoughts, how you're utilizing those and what you're doing in practice in your field as well. This is by far, I think, the smallest font size. I apologize for that. I might just have a quick drink. Moving on to the separate fields of practice that DRR and MHPSS constitute. And we did ask, and this now includes not just the MHPS practitioners, but also DRR practitioners, so all up 31 people that are interviewed in Europe. And it became quite apparent that people in either field did regard the other as a separate field of practice, both in terms of different professional backgrounds that often happen, so to be that engineers, or infrastructure people that might be sort of looking at the architecture of buildings, safety of buildings, that they don't collapse in an earthquake scenario, for instance, but also a mutual lack of awareness of what the other field of practice is actually engaged in. Technical jargon was identified as a key issue here, so really sort of bringing it down to a level that where what we do in our field becomes intelligible to DRR is quite important. But also the lack of MHPSS stakeholder involvement in the Sendai implementation process itself. That there's currently a bit of a lack of mental health expertise in this space, if you like. And I'd certainly encourage each and one of you to become involved with your expertise in particular area, which is very much required in the broader Sendai process as well at various levels. The Sendai vagueness, as I said, Sendai does not specify the mental health risk to be addressed. It's got a content neutral notion of risk, if you like, that has to be filled, I believe, in a particular practice domain, but also has to be consistent with the broader notion as it's specified in the framework. Yeah, I might just flag here another important one, perhaps, that more relates to a paradigm shift that might be required also within your field of MHPSS and our field of MHPSS. People were pointing out we need to move away from, and maybe this relates also to the clinically orientated sort of providers, more away from an expert-based to more participative approach, one that meets the needs on the ground, obviously. From a clinical to more psychosocial or needs-based orientation, from a homogeneous to a more differentiated view of the population, which I'm sure many of you will be sort of working from anyway. But also from monitoring mental health consequences in the response and recovery phase to actually see what we can do in terms of enhancing resilience in prevention and preparedness activities. Now, it's not just challenges in terms of integration, but thankfully, we also identified a number of opportunities. And there are a number of avenues here, such as intersectoral platforms. So for those of you fortunate enough to have worked in projects or in platforms that have brought together stakeholders from these varying communities of practice, this is the place where that conversation needs to happen. And the UNISDR global forums and regional forums and the national platforms that exist as well provide very much sort of avenues in which you could get involved, and I would certainly encourage you to get involved in those as well. Fact sheets, and I think the WHO has obviously done some fantastic work and leading work around this as well. Basic primers around sort of what does DRR and MHPSS, where's the connection? What does it mean? What does DRR mean for MHPSS? Having fact sheets around that is quite valuable. And I think they've just been updated on the part of the WHO as well. So it will be great to sort of be able to utilize them and make them more known as well. As far as our field goes, I think the ability to provide clear, understandable messages in terms of what we can do to provide expertise in terms of disaster prevention and response planning, not just in the response, integrating that mental health knowledge at various levels. Some people went as far as saying marketing our mental health knowledge so that it can actually be utilized by local authorities becomes more and more important as well. So making it relevant and usable. And perhaps also providing guidance on where money, efforts, and time are best spent. And yes, definitely, we need to create the evidence base on actually what works in mental health and psychosocial support. So an evidence base around that is emerging, but it's still emerging certainly as far as sort of the low threshold types of supports go, whereas it's much more established for the more clinical interventions, I guess. I might just flag here a number of interesting linkage concepts and approaches. So the focus on resilience building resonates in both camps quite clearly. Health resilience in particular is built into the Sendai Framework and to DRR thinking throughout. There might be a risk approach there, but resilience is very much part of the picture. And obviously many of you working in sort of mental health, resilience has become a bit of a buzzword over the last 10 or so years in particular as well. So there's clear connections conceptually there. The use of health promotion strategies and of community-based approaches also resonate quite clearly. And some people pointed out to me that the ISC guidelines also obviously have a section within it that talks about community mobilization, so which is very interesting. There's some natural synergies there as well. Health literacy, disaster literacy, there are connections there. Healthy city approaches and urban resilience, and also self-help approaches, so that sort of capacity building to become resilient through the resources you already have in the face of adversity. It's quite important. As far as formal integration goes, some suggestions were raised that we need to operationalize those linkages. So the linkages are there. We need to recognize them and maybe also become clearer about what we're doing in this space. Perhaps we need to use the guidelines we have for MHPSS as an appendix to the Sendai Framework, which could then actually inform the actions that need to occur in this place a bit more clearly, rather than throwing it open to everybody to do whatever they think might be best with the best of intentions. But obviously it's good to know what actually works in this space too, and maybe there's a lot of wisdom and knowledge in our field that can be utilized and should be utilized to good effect here as well to inform DRR. So in concluding, it's in terms of the integration of these two fields, I think it's fair to say that it is early days, and that also Sendai awareness within the mental health field may be quite limited at this point. And I'm happy to be proven wrong on this, and I'm sure I will be over time. Nevertheless, MHPSS is in a good place to inform DRR, and then also in turn to be informed by DRR. Having said that, on the basis of this study, expert identified risks and strategies do not necessarily imply that they are generally well understood or already widely in place. So there are great differences across countries and regions, and some of those things are tied in with resource questions, obviously, as well. And while the inclusion of mental health in Sendai is laudable, its general formulation does not necessarily reflect key challenges and the existing sophistication of the field that we're in, which has been around for a little while now, and the evidence base for some of the interventions or support interventions in particular is also emerging. And we've got quite a sophisticated understanding of mental health impacts more broadly. So therefore, MHPSS needs to guide DRR on the mental health aspects of disasters, and in turn, perhaps within our field, a shift in orientation and further steps may be required to translate DRR into sort of MHPSS policy and practice. So looking then to the future, I think some of the implications that I would like to highlight is that in order to reduce future mental health risks, we might need to de-jargonize both fields. And I'm very happy to contribute that as much as I can as well. We need to harness existing integration opportunities that are highlighted, scope and also better understand mental health risks that are presenting in different contexts, quantify those at population and service levels, and explore effective upstream strategies to reduce mental health risks and further strengthen existing linkages. But also
thank you so much, Lennart.
Yes,
it is such an informative and comprehensive presentation. So rich. We have so many questions and reactions already for your presentation. But and I thank you, everyone. I just want to remind again that if you have any question, you can write on the left side of your screen and the chat box, and we are collecting all those questions to present and give it to Lennart and Fahmy, which we will go straight after the presentation to a question and answer session. So, yeah, now I'm pleased to introduce an old friend that we met in Libya, Dr. Fahmy Hanna. He's based in Geneva now. He's going to take the floor. He has more than 10 years of experience in mental health services and its development in low and middle income settings. He previously served at WHO office in Damascus, in Syria, as a technical officer on mental health during the current crisis inside of the country. And before, he also worked at a WHO office in Libya between 2011 and 2014 as a mental health advisor, providing technical support for mental health programs in Libya. It's when we met. In 2014, he moved to WHO, Geneva, the headquarters, where his main areas of work has been includes monitoring global mental health plans and activities and technical assistance to countries on mental health service development. He does contribute to several WHO products, and including WHO Mental Health Atlas 2014 and Mental Health Gap Intervention Guide, the version 2.0. And since July last year, he's representing the WHO as the co-chair of the Interagency Standing Committee for Mental Health and Psychosocial Support in Emergencies. So as you can see, it's a very extensive profile again. And Fahmy, it's a big pleasure to have you again at this forum. It's not the first time that you are here. And the floor is all yours.
Thank you, Marcio, and thank you everyone for this opportunity. It's really a pleasure to be here and get this opportunity to present. As you know, I always consider myself a member of the MHPSS.net family. As mentioned by Lennart, the DRR and MHPSS link is still in its early days. So WHO, like many organizations working in this field, is learning, is building its knowledge, including the knowledge of know-how. So I thought in my presentation I'm going to share with you in this field who is doing what and why it's needed and what's next. Starting with the why. The why is quite obvious here. These statistics are not from emergency settings. This is the global statistics for mental health workforce in more than 130 countries in the world. As we all know, 1 in every 10 persons would require mental health treatment at any point of time. But the human resources available globally for mental health is 1 for every 10,000. So 1 in 10 need treatment, 1 for every 10,000 globally, human workforce for mental health. When we go to low income countries, this shift into 1 for every 100,000. And even when we look based on this bar chart, if we look at regions like the African region, if you look at highly specialized positions like psychiatrists, we find there is 1 psychiatrist for every 1 million. And unfortunately, some of the services in some of the regions in Africa is dependent on highly specialized workforce. in many countries in the world, the situation of mental health services is being very much institutional dependent, with very limited community mental health care services. So, as was mentioned by Lennart, we don't need a disaster here. Even without a disaster, there is an ongoing hidden emergency in mental health, which is shown by very limited human resource and facilities available, even without a disaster. But when disaster happens, when disaster hits, we know that the prevalence of mental disorders would increase. Not only mental disorders, but also stress reactions, what we can label as non-pathological stress reaction, which can be, according to some estimates, be more than 50% in communities. But if we look at mental disorders ranging from mild, moderate to severe, severe would rise by 1 to 2% according to WHO projections and estimates, and mild to moderate would rise by 5 to 10% to become 15 to 20%. Some might feel that these statistics are not large, but you can appreciate its significance when you apply it to any city affecting by a crisis in today's world. So, for example, if you look like a moderate-sized city like Homs in Syria, which have very limited mental health services, a city with 200,000, you apply these figures, and there are more than 45,000 actually person with common to severe mental disorder. You apply it to a crisis like the one in South Sudan, with more than 7 million people affected by the ongoing crisis and war. You find that more than 1.2 people are having mild, moderate to severe mental health condition. So the why is very obvious here. We need the link between DRR and MHPSS. Many of these points were covered by Lennart regarding the Sendai framework, and one of the key issues here is that we find both aspects, inclusion and participation, are covered. So inclusion is covered actually mainly under priority 4, which focus on building back better, and it's interesting because it's using almost the same terminology used in many of the MHPSS literature, but focusing here on national and local level to enhance recovery schemes to provide psychosocial support and mental health services for all people in need. But this comes under priority 4, which is build back better in the recovery phase. The role of stakeholders as persons with disabilities is highlighted both in the preamble and in section 5 under the role of stakeholders in the framework. And as many of you know, a person with disabilities, according to other conventions, as Convention on Rights of Persons with Disabilities, would include people with mental and intellectual disabilities. And here we find the point on participation covered. So they are not only recipients of service, but people with mental health and psychosocial conditions are part of the response, including planning, designing, and implementing it. At the same time, where in Geneva, there was, back in 2007, the first ever global forum on disaster risk reduction. At the same time, the first ever inter-agency consensus document on mental health and psychosocial support was being launched at the same year in New York in 2007. The mental health and psychosocial support guidelines. It covers the aspects of psychosocial support related to protection and promotion of psychosocial well-being, and also the prevention and treatment of mental disorders. And it represents the gold standard and the key document of interagency agreement on what need to be done. There are many areas of intersection between the MHPSS guidelines and DRR. One of which, if you look at the matrix of interventions across the different domain, the MHPSS guidelines is covering emergency preparedness, response, as well as long-term response. I noticed that Lennart also discussed the community participation and community-based psychosocial support. Again, that's covered. Although there is no specific section within the guidelines on DRR, but many of the existing information in the matrix and different sections are very relevant and in line with the DRR frameworks, including the Sendai framework. WHO has produced many normative tools, including tools like the MHGAP Humanitarian Intervention Guide, which focus on management of set of clinical priority conditions designed and developed with UNHCR, as well as the area of low intensity psychological intervention, where different products were released, like problem solving guide PM+, as well as a WHO IPT guide. WHO is also involved within field operations and also contributing to interagency guidelines and standards. But within all this work, within all these normative publications, I have to admit that the amount of publication and guidance on the area of either preparedness or on the area of the DRR or disaster risk management has been limited when it is compared to other available documents on MHPSS field. One of the very strong areas of link I can see in Building Back Better, as you saw under Priority 4 of Sendai Framework, Building Back Better is mentioned, and one of the key building back action points for countries is building back psychosocial and mental health care services. And WHO got one of its publication titled Building Back Better, Sustainable Mental Health Care After Emergencies. It's available on the WHO website and on MHPSS.net. And this guide document reports from different countries from all around the world, different WHO regions for countries following emergencies, or perhaps in fact because of emergencies, were able to build comprehensive and sustainable mental health care services. If this guide now is, I think is around, I would say 6 years old almost. But you will find if a new publication is released, many countries can be added that did serious work regarding building its mental health services because of, or during, and after emergencies. Countries like Guinea, Liberia, during the Ebola and after the Ebola response. Countries also like Turkey during the Syrian displaced Syrian response, and countries like Syria as well. This is the map from the WHO publication, Building Back Better, Sustainable Mental Health Care After Emergency, and one of the very good examples is Sri Lanka, a country that was hit by years of civil wars, followed by the tsunami, and managed in less than 8 years to build, as you can see, the light color here covers the very basic mental health services, and the dark color here covers the comprehensive mental health care services, moving from less than 33% of all the districts covered in the first map, which have community-based mental health services, to more than 75% of the districts. And I recently learned that the recent update for the map back in 2017 is even more promising, with more darker colors for some of this lightly colored area. In the Building Back report, you can find several learned lessons. What were the success factors? What apply for the Building Back Better? Definitely, I think, to a great extent, can contribute into building our conceptualizations regarding the DRR. These 10 learned lessons in the Building Back report include things ranging from relying on local champions, building not relying on vertical system, focusing only on one diagnosis like PTSD, but addressing the comprehensive need of the population, focusing on building the mental health care system as a long-term plan from the outset, doing some demonstration project. Several of the learned lessons that were the success factors in the countries documented in that report is applicable as well to DRR context. Syria, quite a unique example. This is a map from WHO office in Damascus. Syria classically before the war was a country where mental health services within the Ministry of Health available only at 2 cities, Damascus and Aleppo, and it was institution based in facilities which are labeled in some places as asylums, and with very limited integration of mental health into primary health care, and there were no services outside of these two big cities. Paradoxically, after the war, or because of the war, there was a scale up thanks to the dedicated mental health professional who worked in many governorates in Syria. And as you can see, the services has expanded at primary health care level currently during the war in Syria into actually more cities where services has never reached it before. Places like Homs, like Hama, like Latakia, like Tartus, like Nutra and Dara are having. So it's safe to say that there is a remarkable improvement in mental health care services that was done to mitigate the impact that was happening because of the war in Syria, and this is still ongoing. So this map is from 2015, but I've seen some more recent map where the data are currently being analyzed, where there is more coverage and more efforts to mitigate what the risks of the ongoing crisis. So in the past months, as I mentioned, WHO has been looking in past months for what knowledge and what resources are available in this area, and these are examples, some of which are available in MHPSS.net or on the website of respective organizations that develop this. So there is a fact sheet from WHO on disaster risk management and MHPSS. From also Pan-American Health Organization, there is a guide on disaster risk management focusing on the Caribbean islands. There was also a very helpful resource from IFRC focusing on key actions for psychosocial support in flooding situation and building resilience in such context. I see our colleague from CBM, Carmen is here attending this webinar, and she contributed to developing a very good policy brief by CBM on this topic. So I put the link here. But there are also other organizations who are active in this area, including IsraAid, including IMC, and including World Vision. But I have to say what is available is still limited if it is compared to what we have regarding response. Together with my good colleague at WHO, Mark van Omeren, reading all these available resources, we start an early stage of drafting how a DRR actions would be like for a decision maker before, during, and after an emergency hits. Before emergency, it's about preparation, about trying to reduce the negative events of hazards, trying to reduce the risk of them happening. We want to prevent them from happening. Interventions, as all the interventions relevant to mental health preventions can be applied here, and we have evidence that many of these interventions are cost effective and works. For example, nurses who would be visiting the mother to take care of the baby and contribute to the reduction of perinatal depression. School emotional learning programs which are done at workplace for stress management. Several other programs can be applied here for prevention before the emergency happens, and some sort of preparation. Again, reducing the impact of negative health and well-being outcome if the hazard happens through mitigation. We try to strengthen before the disaster hits what the community structures have and build on it. We try to build the capacity of volunteers, of human resources, using tools like PFA to mitigate the event before the disaster happens rather than after it happens. And then the third point, you are actually preparing for the next stage if a disaster happens by setting up, preparing for treatment, setting up your service, building your mental health and psychosocial response systems. This is the stage where countries would be mapping what exists and identifying the gaps within the system. This is the stage where countries would be looking into capacity building and reviewing the available material, reviewing their existing strategies to include comprehensive community-based mental health and psychosocial responses. And during the emergency, the response phase, prevention should continue because we know that incident can increase. Intervention for mitigation should continue, whether it's related to the community, strengthening the existing community structure, or PFA. But here you should scale up your treatment services because you know that there are more needs that you need to cope with. And at the same point, follow up the guidance provided by the Building Back Better document is that from outset, while you are doing the response, don't think only short term. Don't think about activities that would last for 3 months or six months. Think about the long-term plan and needs that the country would have during early recovery. This same apply also for sphere recommendations during the response, as well as the ISC MHPSS guidance. And after the emergency, from early recovery and onwards, build back better, sustainable mental health and psychosocial care systems, and then you will be back to point A. A good example I'm giving from CBM website. It's linked to the policy brief I just mentioned, but here in this example you can see some of the details of CBM work. I put the link here if you are interested to access this case study about CBM work in Sierra Leone to build a mental health coalition among different stakeholders with strong involvement from the government and involving also local actors from different districts through a comprehensive capacity building program for nurses. That was starting from 2010-2011, before Ebola. So when Ebola hits, this is a quote from one of the nurses. We were ready for it. There were nurses placed in different districts. There were people trained to use the PFA and different available tools to respond to the new crisis. So I think that's a good example, and CBM linked that to their policy brief. As far as I know, one of the biggest ongoing projects related to DRR and MHPSS is currently ongoing in India. It is happening in 5 Indian states, in 6 Indian cities. The project is done in collaboration between NIMHANS, the National Institute of Mental Health and Neuroscience, based in Bangalore, India, together with UNDP and with funds from USAID. The project title is Developing Resilient Cities through risk reduction to disaster and climate change. So that's an ongoing project that where UNDP is working closely with the city municipalities, and NIMHANS came to start introducing a psychosocial component to all the work which is done, starting from introducing psychosocial components in the assessment. In this picture here you can find the field team. I got the privilege to join the field team and learn and observe from their work in some of the slums in the city of Navi Mumbai. So they include PSS components in the assessment as well as in the planning. So in the preparedness plan for each of these cities, a PSS component is added, and the capacity building. And capacity building focus on different sectors. So health, education, social sectors, civil defense, people who are specialized in working with people affected by disabilities. So disability centers are also part of this. Universities, different sectors are part of this. In this meeting, the picture here is the municipality where the group participating were engineers, were logistics staffs, and it's interesting to see how PSS work is being adapted and being used to scale up this preparedness in this six Indian cities. WHO is sitting on the advisory board for this project, and the WHO rule is that we learn, we document the learned lessons, and we look in the near future to develop guidance. And WHO is engaged in discussion with the IC MHPSS reference group also to develop an interagency consensus. But we see the coming 2 years as years of learning, of documenting the best and good practice which are happening until we develop the guidance within 2 years' time as an interagency document. So what the United Nations Office for Disaster Risk Reduction is saying on their website, several inspiring quotes that I think are very relevant to MHPSS as well. According to UNISDR, there is no such thing as natural disaster, only natural hazards. So the potential impact of a hazard is really dependent on how the systems and how the persons in a specific community is ready and prepared to respond to this hazard. Disaster risk reduction is about choices, and this is very relevant to MHPSS. The choice by government and stakeholders to prioritize MHPSS is a key choice. It requires investment, including in the preparedness phase, and also include a different role by the government, where the government is not only responding to the crisis, but actually planning and preparing for it before it happens. It requires a decision. It requires a choice to be made to prioritize MHPSS as part of this and to invest in it. And disaster risk reduction is everyone's business. And I think Sendai Framework, as well as the MHPSS guidelines, highlight this very, very well. It's not only the government, it's not only people with disabilities, but it's really the whole communities and different actors. Everyone got a role to play. Back in 2013, ministers of health of the whole world, 194 member states of the WHO, agreed and signed to implement the Comprehensive Mental Health Action Plan. Comprehensive Mental Health Action Plan does not focus only on emergencies, although it got components which look at emergencies, but it focuses on scaling up services and improving the available services for mental, neurological, and substance use conditions. And here are the 4 objectives, and there is a monitoring mechanism. The baseline was monitored through Atlas 2014, and this year Atlas 2017 will be released, which monitors the progress of implementation after 2 years of implementation of the action plan. And as you can see, the action plan includes strategies for promotion and prevention, which is very relevant, of course, to DRR, but also the 3 other objectives are very relevant, starting from establishing sustainable community-based mental health services, as well as strengthening the leadership and governance, and having information systems which will enable us to, and research which will enable us to monitor as well as learn what we are doing. What's next? Looking into facilitating knowledge exchange in this field. The IC MHPSS reference group has got one task force which focus on DRR. This can be a starting venue for knowledge exchange. Webinars like this, where we hear from you, is also an opportunity for knowledge exchange. WHO is learning from the project in India and looking for opportunities into different projects in different countries to document the best practice, but also we can play a key role both as IASC MHPSS reference group and agencies, including WHO and others, in exchanging what is available from best practice on this aspect. Looking into also developing guidance, which can be an interagency consensus regarding this area, which, as we mentioned, is in its early days. But also we need to measure the progress, and now we have a common M&E framework for MHPSS. Some of these tools were tested already in response phase, but I think one of the things we need to be sure about is that this is valid and can be used also in preparedness stages and in line with DRR conceptualization terminology. I'm going to stop here, but I really invite the participants to share with us their thoughts, what gaps they see, what they would like to see in this area in the future as well. Thank you.
Okay, I just realized that nobody was listening to me, right? Yeah. So are you unmute Fahmy and Lennart? Lennart and Fahmy, you have also the microphone open. So I just said a very nice joke and everybody lost it. So let me go straight then, and I was just commenting on one aspect of your presentation, Fahmy, that was quite strong for me, which is that there is no such a thing like a natural disaster, no? And I think languages are very important. And if we call disasters as natural, we shape the reality and the way that we understand this, the situation itself. And then we shape the response for that. So languages are not only jargons, they are very serious. And I think it's quite a strong statement when you say there is no such a thing like natural disaster. So we have a couple of questions here. I will start with Lennart. And Lennart, I already shared with you the three initial questions that they are from the beginning of her presentation, from Aladdin, Susela, and Christina Harris. And yes, and 10 bar on as well. Basically, Aladdin is asking, I have noticed that the countries considered in the study are high-income countries. Would it be interesting to see some examples in low research settings, and especially in countries that are highly vulnerable to natural disasters? And if you can respond all of them together as well, because we have a long list of questions. How were the ineffective interventions identified? No? If you are able to list some of them. Please list ineffective treatments that we were looking at, the same question. Did they look at short-term and versus long-term interventions? And I will just ask for me and Lennart that I know that the questions some of them are very provocative, but if you can keep like short and straight, would be great. We have a long list of questions.
Thanks, Marcio.
Thank you.
And thanks so much for the questions. They're really important, I think. The point is well made. I think the countries that I looked at were European countries in particular for this study. And I'm certainly not claiming that the risks that were identified there would be universal as such. It would actually be really interesting to see if regional differences would emerge if we were to look at disaster risks in particular areas. But the point is quite clear. The countries that I've been looking at were high-income countries. Having said that, the people that are interviewed were not just working in Europe, but also in all kinds of conflict zones and emergencies across the world, to a varying extent. So their work, their perspectives are informed by work in all kinds of regions that are resource poor and resource rich. But I think I would be actually very interested to look at disaster-prone countries or regions such as in Asia to see what kind of disaster risk definitions we might come up with that might make a lot more sense in those particular contexts. And I'll keep this short. The migration or the emerging risk identified in relation to the refugee crisis, I mean, it's not something that just affects Europe necessarily, but it's something that is context-specific and that happens at this particular point in time, something that we may not have identified had we done the study 10 years ago, perhaps. So that is a very interesting aspect to think about that. As far as ineffective interventions go, people are generally cautious not sort of to dob in interventions, to designate them as ineffective. But I guess there's a difference between what is evidence-informed and what is evidence-based. So a lot of interventions, even in psychological first aid, which are very commonplace, there's still no evidence-based for the fact that they actually sort of make a difference, really. So they're evidence-informed, but not evidence-based. At least we know they don't harm people. It would definitely be good to have more data available on their effectiveness. A classic example of something that has deemed to be ineffective by many in the field, not everybody, is psychological debriefing. I think in the early 2000s, there were lots of debates around psychological debriefing in particular. Some studies identified actually that to have, if you almost force confessions out of people, if you like, to have detrimental effect depending on how it is implied or applied in practice. So there's been a bit of a move away from that. And these days, certainly in the more resource-rich countries, we've got this sort of stepped care model idea that we don't have to sort of shoot with cannons, the big cannons at sort of mild psychological distress, but there's sort of a hierarchy, if you like, of things that can kick in early on, which is more psychological support, psychological first aid and the like, to then sort of more for more chronic and ongoing psychological problems, skills for like psychological, I need more water here, sorry. Skills for psychological recovery might be one of those models, and WHO has just developed some great tools around that as well. And then to more all the way to the more sort of long-term or intensive interventions that might only be required for a sort of a minority, but a significant minority of people who may otherwise sort of find it difficult to get better. So I'm not sure if that fully answers your questions, but let me see, what's the short-term, long-term ineffective treatments here? I think I might have covered them, but let me know if there's anything else I can add or if somebody else wants to chip in as well.
Thank you, Lennart. I have a question here that I will pass to you, Fahmy. It's from Carmen Valle. And she says that the field of disabilities and inclusion, and inclusive DRR, is doing some great advances in ensuring DRR for all. And some of us work in mental health with a very strong focus on the disabilities frame, working under the assumption of mental health being a type of disability. Do you think we are benefiting enough from DRR, or are we still not using the potential benefits of working under the intersection between mental health and disabilities? A good example being advocate to persons with disabilities themselves. I'm also posting the question here.
Thanks, Carmen. I think it's a very interesting question. It's very difficult when you ask are we doing enough, because I think we are definitely an area where there are lots of gaps. So whatever we are doing, we need to be doing more. I think now, particularly in the area of disabilities, we have a big opportunity, noting that there is an ISC task force working on updating the disability, the guidelines on working with people with disabilities in humanitarian emergencies. This is gaining lots of attention and now colleagues in this task force on disability are working on getting the regional inputs. There was a big meeting happening in Geneva last month, but I think they're moving to different regions. I believe they are meeting in Ecuador sometime next month, as well as in Lebanon, and then moving around into different regions to get the regional inputs. We can and we should be doing be doing more. As I see MHPSS reference group, we are very much engaged with this task force. This task force is also involving people people living with disabilities, including with mental health and psychosocial. I think there's lots still to be done, but noting the policy changes which are going now, there is a big window of opportunity to do more.
Thank you, Fahmy. And Lennart, it's a question for you from Ananda. Lennart, in some of my work I have seen that it can be challenged to bridge the hardware versus software divide in DRR, which has implications for the inclusion of MHPSS considerations in other sectoral actions in preparedness, mitigation, and response. What are your thoughts about how to overcome this?
I might have to double check that I understand the question right. So is software MHPSS? Is hardware?
No. Software and hardware, it's inside of the DRR framework as an aspect, and Ananda can rephrase it as well on the chat box. But basically, it's what he's saying is it's a structural and non-structured aspects of the DRR, where it's mentioned hardware and software.
I'm still struggling a tiny bit with getting my head around this particular concept in an MHPSS context. Yeah.
Well,
okay.
What we can do is we have a very long list of questions here. Perhaps Ananda can rephrase it again.
I think best is to be rephrased through giving examples, Ananda, maybe.
Yeah.
What do you mean by structural and non-structural?
So another question, which is a tough question actually. It's a very difficult and sensitive question, especially for today. And I would perhaps bring it to the two of you, which is related to Syria, especially children that are going through an unprecedented crisis. No? It's a question from Lennart. Are we going to use the same interventions that we learned and used before, or shouldn't we come up with new interventions, much more advanced and powerful to fit in the new tragedies?
Is that a question for both of us, I imagine? I'm happy to
I think so, yeah.
Take a start on it. I don't think we have to throw overboard everything that we know works and has been proven to work in mental health and psychosocial support. I think we can add to it and complement it with creative thinking about things that might be done in the lead up to an event, and health passports, registries, health registries, health insurance as well, sort of in those kind of contexts where that might be feasible, are sort of very creative ways of thinking about that. But yeah, look, I'm actually quite, the question is being pointed back to me as an academic. I'm actually almost inclined to point it back to the people who are working out in the field, who are in these roles on a daily basis, and who probably have got ingenious ideas that are not even recognized in terms of, I'd really like to learn from them in terms of what they are doing to build resilience, even though they might be arriving on the scene very much in the midst of an emergency. But what are they doing to make sure that the people affected by this emergency will be better off in the long term, or also in the lead up to those emergency deployments? What are they doing within the organization, and also in terms of collaborating with those countries that they might be going to ensure that what they do makes a difference, a lasting difference as well, in terms of building resilience towards emergencies. So I'm dodging the question a little bit, but also partly because I don't have a clear answer necessarily. I think it's an early stage in terms of exploring what needs to happen here, and I think I'm happy to share my presentation. There are some more specific examples within it that might be pointing us in the right direction conceptually, and maybe also in terms of some of the interventions. Not sure, Fahmy, if you wanted to answer that.
Thank you.
But
Thank you. No, nothing to add, Lennart, from my side. Thank you.
Thank you, Fahmy. A question for you, Fahmy, from Carmen again. The examples you are giving are so clear. We know what works in building back better, but we still struggle in terms of funding to do long-term development work in mental health versus humanitarian funding. Yeah? What's your view on these, and how can we advocate to donors on the relevance of long-term investment in system strengthening?
Yeah, thanks, Carmen. Good, very good and practical question. Yes, mental health compared to other fields still suffer from not being prioritized, and we still struggle to get funding, particularly funds for long-term interventions. And we know many of the examples mentioned in the Building Back Better guide did not require 1 or 2 years. Many of the examples were 5 year plus kind of projects that would require long-term intervention and investment. But remember that one of the recommendations in the Building Back Better book is to build the momentum and get more advocacy through demonstration projects, which can show to different donors that it is possible, and that partners together, including local champions, got the know-how and the evidence to start doing the project, which is a pilot in one location into others. So the key is advocacy, the key is demonstration project, the key is also coordination. Many of the successes in the Building Back Better were not done by one agency, were done through joint planning, where different agencies, different donors funded different parts of the plan. Another opportunity that the area of DRR bring is that most of the work we are doing is done in integration with other sectors. So from the example that I have seen in India, although the project were implementing some of the activities using their own budget, but the different ministries that they were working with were putting some resources as the education ministry or social ministry, because it's benefiting their own work plan. So and we see examples from many different projects that manage to integrate mental health, for example, into the area of HIV, or as some of the work done by CMN integration with neglected tropical disease. Where not always the funds for mental health was used, but also the fund available into areas which are receiving more resources, but also where we have enough evidence that if mental health and psychosocial is integrated, we can achieve better results. So yeah, these are my quick thoughts, but I agree with you. It's definitely a challenge.
Thank you so much, Fahmy. And I just want to remind the participants, if you leave the room, don't forget to go to the exit survey. It takes no more than 5 minutes, but it's very useful for us. And we are starting to come to an end with the last questions. And one question that came up, and perhaps the two of you could comment from, and Lennart, is what you also mentioned during your presentation. We have at least 10 years of the guidelines, Interagency Standing Committee, MHPSS Guidelines, that is there and very much relevant and being served as a reference for the sector. No? And Lennart comments the challenge of integrating it in formal ways. Sometimes there is this impression that the DRR field is too sounding to repeat questions like as mental health would be too much focus on mental health when the guidelines have already addressed it as a multi-layer and not only as an intervention but also an approach. And then we come back to the question why formal integration is still so challenging, you know? And what are the, if in case you know, what are the actions that are being taken to build the bridge or to leave the gap?
Yeah, you left the biggest question for last, I think. It is very important. I was actually really interested to hear that Fahmy also pointed out that the IS guidelines don't explicitly, there's lots of overlap there, but they don't explicitly make reference to DRR as such. Perhaps that's an area within the guidelines that hasn't sort of been explicitly or made explicit as such. I think there's a number of levels at which we can breach here in terms of formal integration, and some more basic ones and good ones, I think, are the fact sheets that have been developed, just basic primers that connect these two things. So if the interest, I think, in this webinar is testament to the fact that people have a craving for a better understanding of how those fields relate and how they can practically relate. Those fact sheets provide a great first basis to start thinking about that creatively, I think. The other practical suggestion was to obviously use the MHPSS guidelines or IS guidelines as an appendix, if you like, to Sendai. Now, in terms of coming up with global agreements, none of that happens in a hurry, and providing appendices to that probably doesn't either. But I'd certainly love to see a lot more input from this field, MHPSS in particular, through the expertise that exists within it, to have structural input in those forums where DRR thinking takes place, that's the regional, the national, the local forums, and so on and so forth, to really make sure that mental health and psychosocial aspects are being put on the agenda. It's something that is quite critical and quite important and quite often outweighs sort of physical health aspects and consequences of disasters as well. Those are my initial thoughts. Fahmy, I'm not sure if you would like to add to that.
Yeah, very good points, Lennart. And Marcio, as I mentioned, at the ISC MHPSS reference group, we have a task force focusing on DRR and MHPSS. One of the deliverables we want to see in the coming 2 years is either a position statement or a guidance note which show some interagency consensus on conceptual and also on terminologies. Yep. And summarizing guidance for best practice in this field. So this is one of the expected deliverables from this task force, because as you rightly mentioned, Lennart, we don't see yet this interagency consensus on what terms, what labels we need to use to describe different aspects related to this field. Yep. This is very much a work in progress. The team involved in this task force include some agencies with active work in this area. The Good Practice Group in Sri Lanka, Israel, World Vision, IMC, and in the future also we plan to have CBM on board, who's joining the reference group very soon. So we want to use it as a venue for knowledge exchange, and within 2-year time we expect to have based on that some good guidance and interagency consensus statements.
That's fantastic to hear. Very encouraging. Mm-hmm.
Yep. Thank you.
Well, thank you so much. I think it's very very provocative again. And I think we are coming to an end of the webinar. And first of all, Fahmy and Lennart, I want to thank you so much. It's so important, the space and the time and the reflections and your studies that you have shared here. It has been, as everyone is already saying at the chat box, how important and informative this discussion has been, and I'm sure this is going to unfold to more discussions, perhaps more specific aspects. And I believe that this is an starting discussion on DRR and MHPSS. It's a long run and very important. Thank you once again. Very much appreciate it. I know that some of the questions we were not able to answer them now. Please do write to Renata, and we will make sure that Fahmy and Lennart can receive them. This webinar, as I informed at the beginning, has been recorded and it will be posted in our social medias. Don't leave this webinar without answering the survey. Again, sorry for saying those questions several times, but they are very important. And I also want to say that in about a month's time from now, we are going to have another webinar that has been scheduled as well on mental health and psychosocial support and coordination mechanisms in humanitarian response, which is also what we call hotspot conversation and discussion. And we're going to also have Fahmy there in this presentation as well. Thank you, Fahmy. Thank you, Lennart.
Thank you.